my intro very brief.
It will be.
Yeah, thank you.
I'll signal you, I'll come up here, and then we'll do the questions.
I'll follow your lead.
And I'll leave it.
Good morning. Let's begin our program. I'm George Thomas, and today I have the privilege of introducing someone who understands the challenge facing the healthcare industry in the U.S. better than anyone else that I know. Dr. Rick Mays is a professor of health policy and chairman of the University of Richmond Department of Health Studies. He began his higher education at the University of Richmond, where he received his bachelor's degree. He then earned his PhD at the University of Virginia and pursued additional postdoctoral education at UC Berkeley School of Public Health. In his early career, Dr. Mays worked at the White House for H.W. Bush on Medicaid policy and later on insurance and Medicare policy for the AARP. His book, Universal Coverage, The Elusive Quest for National Health Insurance, is often cited in scholarly articles on U.S. healthcare. He has also co-authored 2 additional books on healthcare policy. Some of his additional academic contributions include numerous papers related to healthcare, which have been published in the New York Times and a multitude of popular and professional journals. Please join me in giving a warm welcome to Dr. Mays for his first visit to Cedarfield.
Thank you so much. George and Sally, thank you both so very much for having me. This is a huge honor, and this is my first time, so I'm walking around and I feel very much at home because this feels like a college campus. And that it doesn't feel like a college campus because on Friday morning, no students would turn out like this at 10 a.m. There are basically no more classes on Fridays in colleges. My topic today is Medicare and Medicaid at 60. We just last summer celebrated the passage of Medicare and Medicaid. This summer on July 1 will be the anniversary of M1 Day. So they passed Medicare and Medicaid July 1, 1965, but this was the pre-computer era. And they had to go out and find all of the people in the United States that qualified for both programs, and that took a year to fill out with pen and paper and take it to Washington and put it in filing cabinets. So this summer, July 1, will be the 60th anniversary of M1 Day. I will speak briefly about Medicaid. In the beginning, I will speak less about Medicaid and more about Medicare, in part because that's just where I have more training. And I think currently, in some respects, Medicare Advantage is maybe one of the biggest stories in healthcare. So if you're more of a Medicaid person, I'll do my best, but it's not my strongest area. The bulk of this talk will be about Medicare and Medicare Advantage. So that's my outline. I've tried my best. I told George I tried to keep the politics to a minimum. I can't tell you it's zero because it's not possible to keep politics out of Medicare and Medicaid and health insurance. So it will creep in. As you heard from my biography, I will put my political cards on the table. The bulk of my early career, I worked with Republicans, and I worked for Republican senators and the President Bush. I have stayed pretty much the same politically. Republicans, in my estimation, have lost interest in healthcare. It's not one of their huge priorities. They have other priorities, and Trump has very different priorities. So I've kind of stayed here, and then the Democrats have always been interested in healthcare, and so I tend to hang out with Democrats more now just because they're more interested in the topic. So that's my disclosure, and so you know where I stand. So I want to leave time at the end for you all to jump on me and take issue with any of the things I say today. That's the picture from July 4th this past summer, the passage of the One Big Beautiful Bill, which will have profound impacts on both Medicare and Medicaid and have already had profound impacts on the private health insurance market that Obamacare set up. This is one of my colleagues at Harvard Medical School. He's probably the leading health economist in the country, David Cutler, and he seldom, this is in the Journal of the American Medical Association, he's very reserved, he's an economist, he doesn't he keeps everything kind of relaxed and very empirical and analytical. And he wrote this piece in the Journal of the American Medical Association saying, the one big beautiful bill is the worst piece of healthcare legislation ever. And he explains why we're going to see a growing number of uninsured people in the next 5 years, because a lot of the subsidies that are helping people with lower incomes afford private health insurance are being removed. They're already being removed for the individual market, and so there are states like North Carolina that have already seen a 20% increase in the uninsured because they can't afford the premiums. The real big increase in the uninsured hasn't happened yet because the one big beautiful bill, the big cuts to Medicaid have been postponed until after the fall elections this fall. Not an accident. The pain is coming after the elections, and the Republicans are trying to maintain their majorities in the House and the Senate. So when the pain comes, and ironically, it will come in a lot of red states and red districts, or where people are going to lose Medicaid coverage. People that vote Republican, voted for Trump, are going to lose their coverage, and they don't want them to be mad at them yet, or maybe try to not have them be mad at them at all. But that will be coming, the cuts will be coming in 2027, which is not good for people who are going to lose their insurance. I look at it as there's an opportunity before those hit, especially rural hospitals and urban safety net hospitals like VCU. There's still time to mitigate those cuts if we can and try to reduce their negative impact. I gave the link to this presentation. I don't like to give slides with lots of text because it's exhausting, but these are all the details about the magnitude of the cuts. So I can boil it all down for you. The big cuts coming to Medicaid, again, both rural hospitals, urban safety net hospitals, and for individuals who depend on Medicaid, those are required to offset huge tax cuts that have been disproportionately directed at the highest income earners. And so you have to have some offsetting mechanism to pay for those. And even then, I will tell you that even after all these Medicaid cuts are coming and reduced subsidies for private health insurance and some reduced Medicare supports, those offsets will not be enough to pay fully for the tax cuts. So unfortunately, we will be adding to the deficit. And that means more interest payments over time for our children, your grandchildren. And this isn't the day to do it. I don't want to get derailed, but I think that we need to have a bigger discussion about intergenerational equity, about how are we setting up our children in the future for paying for life. Just as a reminder, Medicaid is the single largest payer for nursing home care in the United States. Those have not been the ones that they are going to make cuts to yet. So I think that's good. But eventually something has to be cut because they're going to need more money to pay for bigger deficits. So there will be reduced generosity for the people who buy individual policies on the ACA. And I work with young adults and college students who are going into their 20s. I can't tell you how good it makes me feel to tell students that you can stay on your parents' plan until you're 26, because that didn't used to be the case. And today's young adults have so much more that they have to contend with. A volatile economy, they have more student debt, they need to take more of their 20s to get more education, to advance themselves. At least they don't have to worry about being uninsured if they can stay on their parents' plan. But the ACA is now, the generosity for them then going on to buy individual policies is not going to be as generous to help them when they age off of their parents' plan. Hopefully, the hope is by 26-7, they're employed and they get their health insurance from their employer. But I have students who are in medical school and they don't get out until their late 20s and early 30s. And they're working so hard. I have nursing students who are going back for their advanced nurse practice training and they don't get out until their late 20s and early 30s. And after 26, they're on their own. And they often need help buying their private health insurance. The last thing now, I'm going to segue to Medicare. The biggest story, I would say, in Medicare by far, and one of the biggest stories in healthcare in my generation, has been the absolute massive growth of Medicare Advantage. And I'm just curious, would you raise your hand if you guys have a Medicare Advantage plan? Okay. So maybe not quite half. Can I just ask you, do you all like your plan? You like it? Other responses? Anyone else? Who has the traditional Medicare? Oh, man. If I can afford it, I'm not, no disparagement of Medicare Advantage. If you can get a really good one, they're great. If you have the means, staying on traditional Medicare gives you all that extra choice, right? And then you can buy the Medigap policies to cover all the copays and deductibles. That's the traditional Medicare. Is it perfect? No, it has problems, and we'll go through that. But my parents have traditional Medicare, and it just gives them maximum choice of provider. And I think sometimes with some Medicare Advantage policies, you don't realize until you need it the restrictions on the people that you can go see. They have individual physicians and hospitals, and you can only go to see them, and you may not be able to go see the people that you want, and that's the structure of Medicare Advantage. You don't realize it until you need it, and then you realize, oh, I have limitations on who I can go to, and I have to deal with prior authorization in a way that you never have to deal with that in traditional Medicare. Let me back up. This is Senator David Dernberger from Minnesota, and that's Senator John Hines, who perished tragically in a helicopter accident. They are the founders, they're the originators of Medicare Advantage. And this is more in the weeds. I don't want to get too confused. There was this bill called the Tax Equity and Fiscal Responsibility Act of 1982, and the two of these senators put in that legislation the acorn of Medicare Advantage. And they did it with the best of intentions, and all of us who worked in health policy were excited to see how it would play out. But they were the ones who came up with the idea of saying, hey, let's come up with a standard payment that goes to a health system that will take complete global, just like Cedarfield takes total control and care of you, let's come up with a way for Medicare to make a payment to a health system that globally takes care of all your needs for a year. And in so doing, that system will be much more motivated to do primary care and prevention and reach out to you. And you will always be in one system so that all of your records can be shared with one other provider and everything is in-house. And the thinking was, we'll have better quality outcomes, and from a business model, better patient outcomes and more primary care and more prevention means that over time, per Medicare beneficiary, the spending will go down because you're taking better care of them up front. And it was a way to kind of not always be so reactive in medicine and always do retrospective fee-for-service reimbursement, which aligns the incentives to do more volume of more care downstream when there's more medical need. Medicare Advantage was, let's go upstream and let's take care of people proactively. And when they passed this in 1982 and it went into effect in 1985, these were the health systems they had in mind would take these contracts and take total control and care for a patient, and these were going to then become the models for our country. And these are some of the best multi-specialty integrated health systems in the country. They were the leading ones, and they were, most of them, or if not all of them, were not-for-profit. The Mayo Clinic and Geisinger in Pennsylvania and Intermountain in Utah and Kaiser on the West Coast. And the hope was, instead of insurance companies like United and Humana and Blue Cross that have a more for-profit financial motivation, we would over time take Medicare and turn it over to physician-led, not-for-profit, medically focused organizations. And that would be a great way to get better return on Medicare spending, better value, better outcomes, and let these groups spread across the country rather than for-profit health insurers. That was the goal, that was the original intention, and we were all excited to let physician-led organizations over time take over the program. Unfortunately, almost all of these multi-specialty groups have either had to merge or they've been bought out because they could not compete with the United Healthcares of the world. United Healthcares came in and the Humanas, and these are massive, multinational, for-profit, huge conglomerates. They're health insurers, they own hospitals, they own physician practices, they own pharmacy benefit managers. They're both horizontally consolidated, meaning they buy out all the local providers of one type, like all the local hospitals or all the surgery centers. And then they're also the insurance and they're the pharmacy. So they own everything in certain regions. And they are driven and they are business-led. And United Healthcare employs 10% of all the physicians in this country under its Optum unit. And it's buying more and more physician practices whenever it can. So it's buying everything under one roof, one entity. And that was never the intention of Medicare Advantage. That was never the goal, to turn over the program to for-profit health insurers. But they're smart and they're wise, and they have Wall Street, so they can go on the capital markets, sell stock, take that capital, and go out and buy all the medical provision around the country. And now you have, in the New England Journal of Medicine and the Journal of the American Medical Association, the New York Times, and also the Wall Street Journal are writing article after article saying this is massive corporatization of healthcare. These are for-profit entities that are taking over more and more of healthcare. There has to be some element of for-profit. We are the United States, we are a capitalist country, and for-profit done right and well-regulated, it's fantastic. But we also have antitrust enforcement, because you can't allow one entity or two entities to control whole markets, because then they don't compete, and you have monopoly and oligopolies, and then you have very powerful provider groups, and you have individuals who don't have enough power to push back. I wrote this book with a physician many years ago saying that the big goal that Medicare has always been chasing is, how can we have better ways to pay doctors and hospitals that reward them appropriately, but also motivate them to do the right thing for patients. And there's a joke, this is a famous article saying the three worst ways to pay physicians and hospitals are fee-for-service, capitation, and bundled payments, or salary. And the joke is those are about the only ways you can do it, right? So this was the guy who ran Medicare in 2002 under George W. Bush. And he gave me an interview about the Medicare program, and he let it slip. This was actually, he should not have said this when he said this to me. He could have thought this, but he should have kept it to himself. But he said, I hate Medicare. I hate the way this thing is run. I hate setting prices for hospitals and doctors because it's not really achievable to do it properly. He's like, let them all go buy an Aetna product or a Blue Cross product. That's the Republican philosophy. Why should Tom Scully, the head of the Centers for Medicare and Medicaid Services, why should his staff fix prices for every doctor and hospital in America, which is what we do? Fair point. And because of that, in December 8th, 2003, we started this experiment in full, which is we created Medicare Advantage. And Medicare Advantage is the opposite of fee-for-service. Fee-for-service is every time you go as a Medicare enrollee or Medicare beneficiary, every time you go to the hospital or you go see a physician, they submit individual bills for all the services provided to you. And there are codes, hundreds of hospital codes, tens of thousands of what CPT codes for physicians, for everything that's done to you or done for you. The other option is to go all the way over to capitation and again, just say, we're not going to try to fix individual prices. Here is one lump sum for Rick Mays to be covered by Kaiser Permanente. And Kaiser Permanente takes care of that, all the care that I need, and then it provides the payment to the individual providers that work for Kaiser. And again, the thinking was, oh, this is going to be the way to make Medicare focused on keeping beneficiaries healthy, to be proactive, to do the right thing, and not over-provide, say, MRI scans if they're not needed, or CT scans. Because under fee-for-service, every time you do something, you get reimbursed. So economically, you are sort of encouraging perhaps an over-provision of care, because every time you hit the button on the MRI machine, you get $1,000. Capitation was saying, have your MRI machine, use it appropriately, but don't be incentivized to hit the button every time because you get paid more, because you don't. You get a lump sum to take care of all the people that you take care of. Everybody was very excited when this passed. You can see there was Bill Frist, who was a cardiac surgeon, who was the Senate Majority Leader. Bill Thomas from California was the Ways and Means Leader. And the thinking was, let's let all of those healthcare companies compete, but not over profit, but over who can provide better care for that same capitated amount of money per beneficiary. Make them compete on quality and better outcomes. And then they'll still make money, but they'll make money because they're providing better care. That was 23 years ago. This is the article I published with my colleague this summer saying we have never seen this in healthcare. And let me just break out these numbers for you. So this little bar here is the number of Medicare beneficiaries in Medicare Advantage. And ever since that passed, it has grown 500% of enrollment in 20 years. Traditional Medicare literally has fewer, those of you who raised your hand who are in traditional Medicare, your absolute numbers have gone down, even though the number of people in Medicare has increased by 26 million over the last 20 years. All the growth is in Medicare Advantage. They've seen an absolute massive increase from 6 million to 34 million people in Medicare Advantage. Meanwhile, traditional Medicare has seen an absolute decrease in numbers. Medicare Advantage is such a great deal. The premiums are lower. You get dental benefits and optical benefits and other benefits, gym memberships, and it's all in one product. And they sell it to you when you turn 65, and you're kind of used to that product. And it's an easy thing to lapse into. I'm sure you all know, in a way my students don't know, that if you start off in Medicare Advantage, though, at 65, it's almost impossible to go back to traditional Medicare because they will then look at your medical records and they will risk rate your premiums. It's the last part of health insurance in this country that you're allowed to take into account a person's medical history to set their Medigap premiums. If you start off in traditional Medicare, you can always switch over to Medicare Advantage, and there'll be a lot of those brokers selling you all kinds of plans, and you can't even watch TV in the fall with every other ads on Medicare Advantage. They'll be glad to take you. But if all of a sudden you're in a Medicare Advantage plan and you get older and your medical needs increase and you want to get out of that plan and go back to traditional Medicare, you might find that it's not financially possible to do that. So this is the corporatization of Medicare. This is the for-profit takeover of a public insurance program. An obvious question is, well, does Medicare Advantage have better outcomes? And I can just summarize by saying it has similar outcomes. Basically, it's kind of hard to generalize because it really depends on what your health needs are. But when they look at overall outcomes and patient satisfaction, there's not a dramatic difference overall between traditional Medicare and Medicare Advantage. The outcomes are relatively similar. There are subgroups that then need maybe advanced oncology care or advanced neurological care that might then find their Medicare Advantage plan is not that generous and not what they need. But if you don't have high needs, then you probably won't see a big difference. But here's where you do see the difference. So the outcomes are similar. It's the amount of money we spend more on Medicare Advantage. So to get those private plans to come in and bring them into the program, the government has been sending them bigger and bigger checks so that they can stay in the program. And that means that we are paying more for people in Medicare Advantage than if they had stayed in traditional Medicare. Why are we doing that? Those companies need to have a profit margin in a way that traditional Medicare doesn't have. The government doesn't need a profit margin. And these companies have found out also that they don't want all senior citizens. They want the ones that are the youngest and the healthiest, right? And they want ones who have conditions. This is called upcoding. They want senior citizens who have conditions that can give them extra bonus payments, but they want those conditions to be ones that you can't really do much about. So they get the extra payment, but then they don't have to pay very much. When Obama passed the Affordable Care Act in 2010, if you ever go back and watch his address to Congress, he said, we're going to pay for this in different ways. We're going to pay for the expansion of coverage from different sources. The one he singled out was excessive, unjustified overpayments in Medicare Advantage to private health insurers, to claw some of that back because Medicare is not institutionalized to make healthcare companies profitable. Its mission is to provide care to people who've paid into the system their whole life. So if you see this is the overpayment levels, they do go down because the Obama administration clamped down on the excess of generosity. That worked for about until the Trump administration. And Trump didn't make any huge changes, but at this point in time, the United Healths of the country and Humana's figured out there are all kinds of ways that when a beneficiary comes into their plan, they can send a nurse out to their house, or they can go visit the physician's offices and go through all those medical records and look for anything in there they could add as an additional diagnosis for that patient. And when you add diagnoses, Then the government says, oh, this person is sicker. They send that company more money. And it takes off right about here. And this is where the upcoding becomes, and I'm going to be honest with you, because right now United Health is under criminal investigation. This is when the upcoding became criminal. And they were excessive in finding things. Sometimes they just made things up. And these are physicians who were in the program in Medicare Advantage, and then they left because it just bothered their conscience. They just said, you're encouraged to diagnose extra conditions, because obviously if you don't, United Health and Humana, come and bother you. And they come after you and say, look, we need you to find all the diagnoses there are. If you're a 75-year-old with no health conditions, this is about $5,000 is about what Medicare Advantage gets to take care of you. If you have morbid obesity or diabetes with the complications or schizophrenia, they get extra and extra payments. That is justified if you really have those conditions and if those conditions are really generating more expenses. But as the Wall Street Journal found, a lot of those diagnoses were exaggerated, right? They might have been some hint of those conditions, or they might have been subclinical conditions, and they rounded up. And they rounded up as much as they could, because every time you rounded up, your company got more money. And in the lawsuit that the federal government brought against United Health, this is what's great about lawyers, you have this period of disclosure. You get to go through all the emails in the company and see what were they saying when nobody was looking. And this is one email from one administrator to the physician saying, we want to get together with you and discuss what we can do in the short term and long term to really go after the potential risk scoring you have consistently indicated is out there. You mentioned vasculatory disease opportunities, screening opportunities. Screening opportunities is like going fishing. What can you find in that individual with huge financial opportunities? Let's turn on the gas. And these companies are so well-resourced, they can purchase and develop software programs that go in there and try to find anything that can be upcoded, and it's done automatically. The biggest offender of all is United Health. They're the ones who are the most aggressive in going out and finding people with any condition and then upcoding. Other companies like Kaiser Permanente, which is not-for-profit, does it the least. So this is the other problem. You might want to respond to this problem and just say no more of that upcoding. But it's not like all of the companies are doing it at the same level. You have to kind of parse out who's doing this more and who's doing this less. The most lucrative Medicare Advantage enrollees of all time are veterans. Veterans have full access to the VA, where most of their patient contact has been, and then they get a Medicare Advantage plan as a supplemental. They never use it because they're always going to the VA. And so we are making payments to United Health for veterans who never use that health care at all. And it turns out it wasn't United. Humana closed in on this incredibly lucrative population. And Humana went out looking for all the veterans to sell Medicare Advantage plans to them because they knew they weren't going to use that health care very much. And they can make so much profit off of it. Another way Medicare Advantage plans make profit, and maybe you all have bumped into this, prior authorization. I mean, talk about the bane of so many physicians' existences, how much time they have to spend, paperwork, appeals, my patient needs this, my patient needs this. I'm the one that went to medical school. I'm the one that understands what the patient needs. And somebody somewhere, an algorithm, has decided, nope, they don't get this. And they have to spend their time appealing and appealing. The system will eventually relent. 75% of the cases, physicians will end up winning and getting the care for their patients that they want, but the system wears them down and makes them spend that extra time that they don't have, and they know that X percent of the time they'll just give up. And when they give up, that money isn't spent and the care is not provided. Last year, 50 million prior authorization determinations were made by Medicare Advantage insurers. In traditional Medicare, it was only 400,000. The Medicare Advantage industry tries to do whatever it can to slow spending. So that's part of its business model. So senior citizens who are in Medicare Advantage, if they get to the point where the prior authorization is so troubling to them, they do and they can and they do go back to traditional Medicare, and that's where they get their remaining years of care, but that now costs the federal government. Meanwhile, the Medicare Advantage provider reap the benefits of saying no and saying no and saying no. And these two individuals then have to go out and buy a Medigap policy later, with all of their health conditions, and hopefully they have enough money to buy it. So they pay for the extra, and then the federal government pays for their end-of-life care. And at the end, the Medicare Advantage provider says, great, we don't have to pay for it. This is another article I published with a doctor at Harvard about, well, look, we shouldn't let this happen. We shouldn't let Medicare Advantage game the system. And even Tom Scully admitted, the guy who originally enacted Medicare Advantage, he said, yes, some of these companies' aggressive approaches to diagnostic coding have been completely out of control, he admitted. But if you give them a long leash and let them make unlimited margins, then they're gonna do it because that's what their shareholders are gonna want them to do. And his response is, you've gotta increase the regulation and not let them get away with it. To which I would respond, these companies are so big and so powerful that in some ways they even build that into their model of penalties and fines and regulation. They know they're gonna make enough money that they just build that into their system. Back in 2010, United Health and Humana were about a third of the Medicare Advantage market. Now they're 50%. So these large providers are getting bigger because they're buying each other out and they're taking over more and more market share. And when they get that big, guys, United Health is a top 10 on the S&P 500. It's one of the most wealthy companies on the planet. When you get to that level of wealth, you have political power, right? You don't have to compete as much because you have so much market share and money. All right, I tried to keep politics out. We're gonna come back to it just a little bit. This is famous in my circle. Newt Gingrich, back in 1995, laid out the goal. He did this off the record. He denies he said it, but it's a tape recording of him saying it. That was the goal all along, was to get Medicare privatized and get it into the Wall Street, to have senior citizens all be insured, not directly by Medicare, but by a private for-profit intermediary. And his argument, to his credit, is that that's competition. That competition will produce better results because that's the American way of capitalism. And Medicare should not be run by the government, it should be run by private entities. That was his goal. He said, but we have to be discreet about that. We have to be subtle about that. We can't be explicit because people won't like that. That was 30 years ago, Newt Gingrich. You guys even remember Newt Gingrich anymore? Project 2025, Trump administration. They're not even hiding it. You guys can go online and look at it. The Project 2025 Medicare for Leadership Conservative Promise includes the following goals for reforming Medicare. Number one, make Medicare Advantage the default enrollment option. That's not the way it is. That's not the way it's ever been. But you make it the default option, I mean, we'll be up to 75% in Medicare Advantage if you make it the default. Give beneficiaries direct control of how they spend their Medicare dollars. Okay. Remove burdensome policies that micromanage MA plans. I mean, that was written by the industry. Burdensome policies is regulation. That's what keeps them, you're trying to keep them from bad behavior, right? And they want to have that removed. It's hard to get people to go on the record, although I have interviewed them, they don't want to talk about it, unless they're fully retired and don't care anymore about the repercussions. But some of the people that were Republicans who worked on the Medicare Advantage plan back in 2003 were like, oh, this is not what we intended to do. It has evolved in a way we did not intend, and we need to reform it to bring it back to a plan that uses competition with good regulation to do two things: to provide the best quality care and a return on investment to the taxpayers, so that we don't overpay private corporate entities from the public treasury. And they are starting to see more and more of these articles saying we need to reclaim the core mission of Medicare as a public health insurance program for the people that paid into it and who would now receive it, and then people like us and our kids who are now paying and will one day depend on that program as well. In conclusion, these are the policy points that we found, that those overpayments for so many years have provided an enormous amount of power, both political and financial, by the largest Medicare Advantage plans. They then take that financial power, they lobby, they advocate for themselves logically. We think that Medicare Advantage should be reformed, that we should get away from some of the gaming of the upcoding. I don't know if those who've bought MA plans, did you use a broker to help weave through the 30 to 40 options that you have when you buy Medicare Advantage? at a certain point, human beings cannot compare 30 to 40 options. It's just numbing, and so you just kind of capitulate. We want to regulate Medicare Advantage down to 3 categories: silver, gold, and platinum. Silver being maybe the least generous benefits, gold being in the middle, and platinum being, I want Cadillac benefits and amenities, and I'm willing to pay more copays. Limited to 3 categories, only those categories, standardize the benefits and the copays, and then make those companies only make one bid, their lowest bid, for each of those categories. So you choose from 3 to 4 options, not 30 to 40 options, and make them compete on price. The savings, that last point, if we can rein in some of that excessive overpayments to Medicare Advantage, let's go back and do one of 2 things. Let's shore up the Medicare Hospital Trust Fund to make sure it's going to be solvent for the foreseeable future, and or probably, let's make traditional Medicare a better package. Let's consolidate Medicare's Part A, Part B, and Part D, and make it more understandable and a better insurance plan to compete better with Medicare Advantage. So that's our goal. And then I'm going to conclude by saying the Supreme Court has weighed in on this before. So to pull back from the politics and go to judicial review that's thoughtful and principled. In the year 2000, the Supreme Court weighed in on what should Medicare spend its money on. And their argument is Medicare is a public health insurance program that is primarily for the beneficiaries to take care of them, but it's not solely for the beneficiaries. It's also to advance medical education for medical students. It's to provide enough provision of care in a community for people who then might need charity care. Medicare spending should increase the provision of high-quality medical care in any community, not just be for just the beneficiaries, but definitely not for for-profit companies. So I'm gonna say that I agree with the Supreme Court. And this is back when the Supreme Court was maybe a little bit less politicized than it is today, so I think they're right. Thank you very much for listening to me, and I'd be happy to answer any of your questions. Thank you.
Any questions? I wonder, is this genie out of the bottle? Can you put this back together again?
That's a great question. Can we rein it back in? Oh, the question is, can we, like, the genie's out of the bottle. This thing is already kind of, I hate to use the term metastasized, but it's out there, and these are powerful corporate interests. Can we get it back? It's going to be hard. I think the press is, look, that series that was an expose of the Medicare Advantage industry ran in the Wall Street Journal, which is more effective than it would have run in the New York Times. The New York Times, okay, we kind of expect them to do that. That's going to be their position. I applaud the Wall Street Journal, and I think we need more of that. And that article had a profound impact because there were investigations in Congress. Chuck Grassley from Iowa took those articles and hauled in those Medicare Advantage CEOs and said, you have to explain this or we're coming after you. So I think we can push back and say, yes, as a company, we understand that you have an obligation to your shareholders, but there's a bigger obligation to the American taxpayer and to beneficiaries that is more important than United Health's profit margin.
Got it.
I read yesterday that Google, is it working?
Well, yeah, it's working. It's just you have to finagle it.
I read yesterday, you hear me? That, no?
I'll repeat the question. I can hear you.
I read yesterday that Google has a pilot program where they are collecting data on Fitbits of everyone who has provided health care to a person. So that, for example, if I have 10 places where I've had my health care here in Virginia, they would have all the information, which in some ways sounds okay. Everybody can talk to one another and know what's going on. But on the other hand, AI will take this information and analyze it.
Yeah.
And obviously, with what you're talking about in terms of upcoding, et cetera, this is really questionable.
It is.
So I wondered if you would comment.
The sharing of medical data, right? How personal that is. And these companies are aggregating and scraping off all of this that they can collect for their own purposes. I think it's very disconcerting that we may not be able to maintain the level of privacy. I was not aware of that article, but I can see why. That's Google's mission too, is to obtain as much street level information for driving, and if they can get medical information, that can be sold, right? That can be provided to companies so they can know who you want to enroll in Medicare and who do you want to avoid. The old joke about Medicare Advantage was to avoid getting enrollees who might need health care, they would only put the enrollment office on the 3rd floor of a building that had no elevator. All right, so sorry, if you couldn't get up there, you stay in traditional Medicare. We're going to have more regulation about that, absolutely, because it can be exploited. And do you trust Google? I don't know. Yeah. Yes.
Switch gears just a little bit. I do still practice medicine part-time, and my blood pressure is like 220 right now because you have reiterated what I've been telling my family for years. But let's switch to another question. What are your feelings on the Josh Hawley, Elizabeth Warren bill as far as breaking up big medicine?
So the large, this is like going after antitrust for large hospital groups?
The verticalization of care. So it's Josh Hawley and Elizabeth Warren going after the verticalization as
Yep.
far as trying to break up the for-profit status versus helping patients,
Yep.
which is what Medicare is supposed to give.
I think it's good. I like to see the bipartisanship on that. I think Josh.
How about repeating what's good?
So there's a bill, and I'll confess to you, I'm not kept up on the specific details of it, but I know Elizabeth Warren's been working on this. Josh Hawley, the senator from Missouri, they are pursuing legislation that will break up some of these really large medical conglomerates. They're vertically integrated, so they're hospitals and physician groups and pharmacy benefit managers and outpatient and infusion centers that have gotten so big in certain parts of the country that they control healthcare for whole regions. One of the classic examples is UPMC in Western Pennsylvania, University of Pittsburgh Medical Center. They own pretty much everything and all there is in Western Pennsylvania under one medical entity. And so they don't have to compete anymore, right? They control it all. I think this bill they're responding to the abuses that come out of that. Two kinds of abuses. Number one is they can charge whatever they want and make insurance more expensive for that reason. And then for physicians who have to sign non-compete clauses, if they work for one of those entities and then they have a difference of opinion, they don't like it, they can't stay in that area because they've signed a non-compete clause. They have to leave the geographic area and go move themselves and their family to work somewhere else. I think this falls under general, more robust antitrust enforcement, which we definitely need in this country. We do. Yes, I think coming over here.
Mike's
And then in the
coming
back,
down.
I'm sorry, I don't see who did first.
After listening to the program, I have traditional Medicare. What are the threats to my traditional Medicare besides Medicare Advantage?
The one threat is the solvency of Hospital Trust Fund Part A. I don't think it's going to happen in your all's lifetime, and it won't be the complete insolvency. What I mean by that, I mean is that over time, the outlays, the expenditures that we're paying will be lower than the money coming in on tax revenue. And then you'll have one of two options. You'll either have to take more money from the general treasury to offset that, or you have to reduce the generosity of hospital reimbursements. So that's the main threat, is if we don't get those costs under control, eventually something has to give. We have to get more money from someplace else, or we have to limit your access to hospital care and physician care as well, or make the co-pays and deductibles bigger for you and put more of the burden onto you. That's the threat in the future. And right now, we're actually already in that state where I think they keep bumping it up. It's 2032. We're going to have a lot more money going out for Medicare than enough tax revenue coming in to pay it at a 1-to-1 ratio. The other option we could do is like Denmark. Denmark just raised its retirement age to 70. this is not the audience to ask about increasing the retirement age. We could do that. It's not going to happen politically. And raising the retirement age might make sense. You might be able to make an argument for people in certain professions, but there's a large part of our population who do manual labor, hard labor, physical labor. They're barely making it to 65. And if you raise the retirement age on that group unilaterally across all, you're going to be doing real damage to people. So we can't just unilaterally raise the retirement age. Another question?
Yes, I've been in a group and they've been studying this little, and in the Biden administration, they were doing pilot programs. The first one had a big problem. They altered it, so I don't know where but it was moving more towards the Advantage type plan.
Yeah. In the traditional Medicare, I think the proportion is about 50% of those people in traditional Medicare are in a Medicare ACO, Accountable Care Organization, which is trying to do what Medicare Advantage does, but do it without the profit requirement. And they keep studying these different pilots of Medicare ACOs, and what they tend to find is modest improvements in patient quality and outcomes, modest savings, but so modest that in the end, hardly really worth it all. So a lot of effort made with very small outcomes, small improvements in quality, and small savings. So they're kind of finding disappointing results. Everybody's looking for the holy grail of what's the perfect way to pay the best organization to take the best care of beneficiaries and then magically reduce spending by 25%. We're still looking for it. It's elusive. Yes?
Is it any more complicated than just raising the earning level that you...
Raising the earning level?
Yeah. I mean, there are people whose payment to Social Security and Medicare is their first paycheck of the year. Okay? That's
Right.
just not right.
So I think it's, so these, the payroll taxes we pay into Medicare and Social Security have not been raised, and there's also a cap. There's a cap at maximum income. I forgot, you all could Google it. It's like 200,000 or something. 175. If you just lifted that to like maybe $1 million, it would flood the treasury with extra money. And there are people out there at the high level of income, they probably wouldn't even feel that or even notice that. So that'd be a great way to get more revenue in. I wish I could tell you, why we haven't done that politically, right? Wealthy people don't want to be taxed more, and I think they probably should raise that. They should. It's also true that about the top 20% of earners in this country pay about 80% of all the taxes in this country. So we do have a progressive tax system. The bottom half of income earners almost pay no income tax at all, and some Social Security tax, they definitely do, but not a whole lot. So we could tax the wealthy people more. I'd have no problem with that, but that's just this Congress is not looking to raise taxes at all. They're cutting taxes. But you're right, we could raise the cap, and that would be a lot of extra money coming into the system. Yeah, that's a good point. Yes?
I don't want to be too cynical here. What's the prospects of our prosecuting all of the fraud that we have discussed today, or potential fraud?
I'm sure you all saw in the news, in addition to this Medicare Advantage fraud, there's been Medicaid fraud in Minneapolis and Colorado on excessive reimbursements for autism treatment. I'd like to tell you that we have all the resources in our regulatory agencies to go after all of that, but we don't. CMS has always been understaffed, and thanks to Elon Musk and the Doge reduction in government employees, we have been gutting agencies that are there designed to be regulating these entities. So I can't be really positive right now that we have the level of government employment in those regulatory agencies to hold them accountable. They can be prosecuted. There are prosecutions going on right now that will probably end up in a settlement in which the companies do not admit fault, and they'll just pay a big penalty and they'll move on. And that penalty might seem like a lot to you and me, but relative to their earnings, it's almost like a cost of doing business. So I'm sorry to add the cynicism back to you.
Well, it would have been helpful. But let me ask you this. This is the most important question. What other topics do you have that you could bring to us next year?
The midterm elections, I can't do midterm elections. Gosh, whatever you all,
We'll take you out to lunch.
no, yeah, I've heard the food here is great.
We tried to today, but he's such a busy man at the University of Richmond, he couldn't even stop for lunch.
Yeah.
So,
All kinds of great topics we can talk about. There's one more, right here, sir.
I have traditional Medicare and a Medicare supplement insurance through United Healthcare. I think you also mentioned that in Medicare Advantage, United Healthcare is reaping big profits.
Yeah.
So they're on both sides.
They're
of the
getting
deal.
both sides. My parents have United. I mean, some of those Medigaps are great policies. I mean, they really cover all your out-of-pocket expenses. They're making money off of that too, because they have a big risk pool, and they've done all the analysis. They know how to set the rates at the way they're going to make money. So,
Yeah, I like what I've got because I can go whatever doctor I need to. I can get in there.
and that is great when you need it, right? You just don't want to have to worry about the financial pressure, and you don't want to be restricted in who you can go see. So that's why traditional Medicare, if you can afford it, I'd stay in it forever. It's the best. Yes.
My doctor's a concierge doctor, and their practice is in an ACO.
Okay.
And recently, they gave a description of it that I passed on to a friend of mine who's a doctor and studies this all the time. And he said, "You're in a good ACO. They're not going to try to take you out of Medicare." My question is, are there good ACOs and bad ACOs?
Yeah, there are good ones. I mean, I don't know all of them, but there are. The general rule of thumb is if that ACO is physician-led, not corporate executive-led, but led by MDs, they have better outcomes, higher quality, and they have less problems with understaffing, with prior authorization. Try to find ACOs that are physician MD-led.
Wait, I know people that have were federal employees. They have great insurance, great options. Why can't we offer that to everybody?
The federal employees.
Combine the two.
Yeah, the federal employees health benefit plan, like CalPERS in California, is one of the greatest health insurance programs for workers you could ever get. Part of that was if you work for the government, you don't earn as much income, but you get these amazing benefits that you can't get in other places. I'm so glad you mentioned that, because the people that came up with Medicare Advantage, that was part of their model was, let's make the federal employees health benefit model for senior citizens. And we'd have all these different options. It's just that over time, Medicare Advantage has been overtaken by one or two in a way that the federal employees health benefit program has not. So maybe that's the way to get back to, is have more robust competition by more Medicare Advantage providers, not just Humana and United Health. You might get better outcomes. Yes, sir.
This is a little bit off the subject, but what are your thoughts about the great disparity between billing and reimbursement?
Oh my gosh, billing and
a CT scan, and they billed $12,000, and Medicare and my supplement paid $700.
$700. So the question was, how can you reconcile these absurd list prices, billed prices, versus what they accept as payment in full? Give me 1 second. I actually have a specific response to that. And I'll end on this, okay? So these are my lectures to all my pre-med students and healthcare students. I'll come back and give this next time. Hospital billing, how about that? Okay. My son, last April, almost 1 year ago today, had emergency appendectomy, appendicitis. when you're in a crisis, you're not thinking about billing or payment. You're just grateful you have health insurance and you care about your child and you're all distracted and emotionally upset. He got great care at Henrico Doctors Hospital, phenomenal outcome. Took him home one night in the hospital, low intensity, step down unit. Took him home, he recovered, and like all Americans, the bill comes a month later. I get the bill, if you can see this, $152,000 and $153,000 for an appendectomy and one night in the hospital. Now, the first thing I go to with my wife is, this is not a bill. Thank you, Lord, this is not a bill. All right, so I just send this immediately to my HR, human resources person, saying, can you please get this figured out? And then 4 weeks after that, after my employer, University of Richmond, works with our insurer at the time, Cigna, and negotiates with Henrico Doctors Hospital, the bill charges of $152,000 come down to $10,000, which is a 90% reduction. So the contract discount is I got a $142,000 discount, and then my patient responsibility is about $2,500, $3,000, and my employer pays $7,000. That is ridiculous. You should not send that to people. You should not even come up with bills like that, because it conveys all people's natural empathy and sympathy in the healthcare wars is with doctors and hospitals, the people that actually provide the care. My sympathy is not with the insurer. My instinctive sympathy, loyalty, compassion is towards the people that provide the care, except when they send bills like this. And then I say, look, now I'm almost sympathetic. I almost feel more fondness for Cigna, which I've never felt fondness or emotional or anything for an insurance company. But what they're saying is they're the ones that inject the reason into this and push back on absurd billing. And for a moment, I'm like, okay, I see what you're doing. I appreciate that. But this should never be happening in the first place. This is ridiculous. And this is the insanity baked into the pricing of U.S. healthcare. When you go to other countries, the prices are transparent. You see them in advance, and they are standardized and universal countrywide. You can go to Japan, $100 MRI. The same MRI you get charged $1,000 for here, but maybe you don't care about being charged $1,000 because you paid your $25 copay or deductible and you walk away from it and you let the insurance battle it out. But that battling out all still adds excessive spending to the system, which bloats the system and then makes health insurance itself more expensive. It's a feedback loop, and you never get away from it. So to your question, where do they come up with these prices? They make them up. And they set them artificially high, and then they negotiate down, and in a perverse way, you can see how worked up I'm getting about this. In a perverse way, you almost get this and you think, oh my God, I'm so grateful to everybody that I'm only paying $10,000. So psychologically, this sets you up. It overwhelms you, and then you think, okay, I'd be happy to pay $10,000 because it's less than 10% of what you were going to bill me. Yes.
If you did not have insurance, you would have that bill.
And you would just have the bill, and they might or might not negotiate with you. So being uninsured is terrifying. It's unacceptable. You can't do it. Wow, he didn't want to end on that note.
Well, I think that was
We have the highest healthcare prices in the world. I'll come back next time. We'll talk about all the origins of all of this, how this insanity got started and what we're doing. I do want to, let me end on a good note. The medical professionals in this country, I train nurses at UVA, and I have pre-med students. You would be so encouraged to see this generation and how like their previous generations, they're going into medicine for the right reason. Yes, they want to have job security. Yes, it means something for them to be valued in society and to be respected. You can have mixed motivations for the things you do, and you should. That's what being an adult is. I have all kinds of mixed motivations. But you'd be so proud of these young adults who are going to give away a decade of their life to go be a doctor when their accounting and finance friends are going to make big bucks the first year they graduate. They're going to go to med school and nursing school, take out loans, make payments to be there for us, to take care of us. And the care I get, the care my son got, the care my parents get on traditional Medicare in Florida is the best in the world. So when you get the care, it is awesome. And people who are rich in other parts of the world fly here to get our care because our care is the best. Our system for paying for it is the worst. Mm-hmm. But our quality of care is unmatched. When you have good insurance, you have a concierge care. My parents have concierge care. Man, that is the gold standard. You can go in any moment, have a half-hour appointment. They coordinate all your specialty care. I wish everybody had concierge care. If you get all of that, you get the best care in the world. So we just got to find ways to make that a little more accessible for more people. Amen? All right, I'll close this in prayer. Thank you all very much.
Thank you so much. Wonderful. And I promise you